And good evening, everyone, and thank you for joining us tonight. My name is Dr. Bill Tullo, Medical Director here at OCULUS, and welcome to tonight's clinical webcast, How Do I Explain Myopia Management to a Parent? You have a text box on your GoToWebinar screen where you can enter questions at any time. We're saving some time at the end to discuss them at the end of tonight's webcast. Tonight's speakers, I'm excited to announce, are Dr. Andy Morgenstern and Dr. Jacqueline Theis. Dr. Morgenstern is an optometrist at Walter Reed National Military Medical Center in Bethesda, Maryland. He also serves as the Director of Evidence-Based Optometry Committee at the American Optometric Association. The EBO committee is tasked with producing all the evidence-based clinical practical guidelines for the AOA. He received his undergraduate degree from Boston University, where he was selected as the 2012 Distinguished Alumni Award recipient, and he continues to serve on the BU Dean's Advisory Board. His optometric degree is from Nova Southeastern College of Optometry, where he was selected as a 2015 Distinguished Alumni Award recipient. He completed his training at the Bascom Palmer Eye Institute at the University of Miami School of Medicine. Dr. Morgenstern is a fellow of the American Optometric Association and Distinguished Fellow of the National Academies of Practice. Dr. Morgenstern is also a recipient of the 2019 Orion Award, the highest award bestowed to the Armed Forces Optometric Society. He's an assistant professor in the Department of Surgery at the Uniformed Services University, the United States Department of Defense Medical School, where he serves as the president of the International Keratoconus Academy and is the past president of Maryland Optometric Association and the Optometric Cornea, Cataract, and Refractive Society. On October 25th, he'll be celebrating the 35th anniversary of the greatest baseball game of all time, which he attended as a kid, when the Mets beat the Red Sox in Game 6 of the World Series in the Bill Buckner game. And now, Dr. Jacqueline Theis is completed her optometric and residency training in neurooptometry, binocular vision, and children's vision at the UC Berkeley School of Optometry. After residency, she became an assistant clinical professor and was the founder and chief of the UC Berkeley Sports Vision and Concussion Clinic. Simultaneously, Dr. Theis was also a clinical staff optometrist at Kaiser Permanente in Northern California, focusing on pediatric patients as well as neurooptometric cases. She has clinical experience in myopia control with both atropine and contact lens modalities. Dr. Theis is an international lecturer on oculomotor eye movement disorders in the systemic and neurological conditions and is currently on the AOA evidence-based optometry and vision rehabilitation committees. I'm looking really forward to hearing the discussions tonight on tonight's presentation. Welcome, Dr. Morgenstern and Dr. Theis.
Thank you, Bill. Thank you very much. All right, so thanks again. I just want to thank OCULUS for putting this on. This is a really important topic. I want to thank my colleague, Dr. Theis. Bill, I definitely want to let you know that our combined brain power probably doesn't add up to half of hers. I really look forward to hearing what Dr. Theis has to say about her experience and also her insight in myopia management. So real quick over here, and a couple of disclosures. Dr. Theis is a consultant for C-Light Technologies. She's a consultant and an advisory board member for Vision Science Labs. She has, Dr. Theis, is that correct? You have no financial interest in the device, the Myopia Master we'll be talking about later today?
Correct.
That's great. And we are both receiving an honorarium from OCULUS for this presentation. We want to disclose that as well. I don't receive any, I have no financial interest in the device. I don't receive any compensation, but I do want to let you know that I'm currently developing an independent myopia report that can print out and give to the parent or actually keep for your records in your office. And like I said, I am receiving an honorarium for this, for full disclosure. And so let's get going over here. So, Bill and I go back quite some time. We were both at TLC Laser Eye Centers for a while. And that's pretty much where I kind of cut my teeth learning a lot about refractive power of the eye, and really the ins and outs of what a contact lens can do to an eye, how light really moves around inside and outside the eye. And I think for people that have some sort of a background in refractive surgery, to be honest, are a little bit of an advantage because they really take a really good look at what has to be done prior to surgery to get the eye really neutralized in a refractive sense, so a refractive procedure can take place. Well, fast forward a little bit, a couple of years, I started working with my colleague Beth Naib, who Bill and I worked with at TLC for quite some time. She was actually the director of the evidence-based optometry committee at the AOA. Unfortunately, and very sadly, she passed away. And she really started developing these very high quality, very strict evidence-based clinical practice guidelines. And since I worked under her, when she passed away, I stepped into her role as the director of the evidence-based optometry committee. Our papers follow a pretty rigorous process, and the process is really derived from the Health and Human Services, U.S. Department of Health and Human Services guideline, clinical practice guideline process. And each of these papers, the clinical practice guidelines, takes about 2 years. Well, we had a request to come up with an evidence-based clinical report, which did not go, to be perfectly honest, it goes through a slightly different process, but the process is virtually the same. And we got this guideline done, this clinical report done in about 5 to 6 months. And as you can see, here are the members of the report. This report is, obviously we have no financial interest in it whatsoever. It is free and available to anyone. You don't have to be an AOA member. If you go to the AOA webpage and look for the evidence-based clinical practice guidelines section, you'll find it there, and there's a PDF on it. So if you forget everything that we talk about and don't have access to the recording when we're all done, you can access this 24/7 on the web at the AOA webpage. And you can see here we have quite a diverse group of people from all different backgrounds, all who have pretty significant myopia management experience. And so we developed this clinical report on myopia management. And I think it's really important to understand the methodology and how we developed this thing. And we're going to go through that in a second. The one thing I wanted to pull up here is that none of this information is really new. And this information derived from, obviously, in our guideline, in our report, it derived from purely evidence-based information. So this was no opinion. These were not single case reports of single individual patients. These were all from high quality evidence-based papers. Now, if we rewind about 5 years, myopia management was really coming on the scene in the United States, really at the end. I mean, obviously, people like the folks down at the University of Houston, Earl Smith and his group have been talking about this for years, so on and so forth. But really, it really caught mainstream attention in the eye community somewhere around 2010, in that ballpark. And so much so, and it became such a big topic because so many kids in the United States and around the globe were becoming more myopic. The FDA, right here in Silver Spring, Maryland, I'm in Bethesda, Maryland, held a workshop called Controlling the Progression of Myopia, Contact Lenses and Future Medical Devices. And that was back in 2016. And if you look over here, these are the organizations that were actually represented at this workshop. It was a packed room. I was in there. There must have been at least 300-400 people in the room in that time. And we had representatives from every organization really coming together to agree on quite a few things over a couple of days. Specifically, number one was, what was the right device to use, or what was the right test to perform? What devices or drugs work for myopia management? How long do you need to keep them on it? And so really, they sat down and put it all together. And so a lot of the stuff that we're going to discuss today has not really changed. But there's some stuff that was stressed by all of these organizations that we stress based on the evidence that we found in our clinical report. So one of the things you can see as an output from that workshop in 2016 was this paper. This is a review article, and all of the people that are listed there are representatives from all the different societies, including in optometry, Jeff Wallin, Mark Raboy, Gene Hillmantle, and Chris Quinn. Chris was actually the president of the AOA at the time. Jeff, obviously at Ohio State, who, if you're a student of his, you know his work. And he has written a ton of stuff. He was the primary author of this review of the workshop. And you can also see the last author on this paper is Malvina Edelman. And Malvina is the ophthalmologist in charge at FDA for ophthalmology drugs and devices. And so this is a pretty significant group of folks over here. And I want to go back and just bring your attention to the fact that ophthalmology and both optometry were at the table. And also there was a representative from the Society of Pediatrics there as well. We went back and developed our clinical report last year. We presented it at the AOA conference in June in Denver this past year. And it's gotten really great circulation. And quite frankly, I think it's helped people out a lot because it really gets into the nitty gritty of, you know, what tests are needed for myopia management, what equipment do you need if you're going to do it, when should you start treatment, when should you finish treatment, what devices and pharmaceuticals are there. And basically, we kind of cull down all the information on things like atropine and multifocal soft lenses and orthokeratology, all of which are great devices. We get into talking about spectacle correction. And for the purposes of the paper, we didn't mention any brand by name unless it was FDA approved at the time as well. And so how did we develop this? Well, what we did is we got the group together, and we're going to get to the part about how do you talk to a parent. But I think what's really important is the methodology of our paper really drives the discussion with the parent. Because what we did is we got the group together and we sat down and we said, what questions do we want our paper to answer? Not let's go through this and just get all the information possible, but we were looking for specific information. I'm going to toggle right now, or try to toggle.
While he toggles, one of the things I wanted to say about the clinical report that was so amazing to me about it, aside from how quickly we got it together, is that it's really digestible. So for those of you who've read a lot of the other clinical guidelines, and those clinical guidelines are excellent as well, but they're very long. And what I love about the myopia management paper is it's very succinct. It is 17 pages. It is digestible. It just gives you straight up the facts. And I love that about this paper.
Yeah, thank you very much, Jackie. So here's a question list that we had from it. And so you can see we went down through every different category of everything that we wanted to answer. And we took these questions and we did literature searches to find the papers that answered all of these questions the best. And so you can see the categories. We had risk factors, genetics, epidemiology, treatments, follow-up, complications of myopia, devices, testing, communication, and this is where the parent information comes in, the FDA approval, what's the deal with axial length, are there alternative treatments, and also refractive surgery considerations. And refractive surgery is a really big component to this because, you know, we're dealing with kids. Last night, Jackie and I had a pretty long discussion over the phone about all the things we could discuss. We don't have enough time to do it all, but refractive surgery is something that she's going to get into at the end and the considerations of it. So what's the most important part about talking to a parent? I think it's important that, you know, we know all the scientific language. I think the most important part is that that second line on the header, their child is their most important anything. It's more important than their house. It may be more important than their spouse. It may be more important than their job, and likely is. The child that they're bringing in is their most important anything, and parents want to know what you're doing to their kid. And the reason why that's important is because for a large portion of these patients, we're explaining myopia management to them for the first time. And I would say probably well over 90%, unless the patient's coming to you because they had a colleague or a friend or a family member that has a kid in active myopia management. Most of these folks don't really use it. So I think it's important to use images, have a computer screen or a monitor up on your wall so you can show them pictures of what we're doing and how we're doing, use analogies. In terms of devices, when I talk to other doctors about this, one of the best analogies that I use is as it relates to axial length. And so axial length, all of the devices that we use, whether it's soft contact lenses that are multifocals or orthokeratology lenses or atropine, the goal of the device, the reason why we're putting them in it is to slow the axial length growth of the eye. And if your goal is to slow the axial length growth of the eye, you have to measure the axial length of the eye. And the analogy that I use is just imagine going to a weight loss clinic and they don't have a scale there. Well, you can't ask the patient to say, well, how many belt notches have you lost over the last month or so? That's not an accurate way of measuring weight. You have to put them on a scale and measure their weight from visit to visit. I think it's the same thing with axial length. Jackie, do you have any, right off the, I mean, we're going to get into the nitty gritty, but in terms of using straightforward languages or images, do you have any other tips or pointers that you like to really kind of headline when you're talking to parents?
Well, I think, it takes a lot to understand the parents themselves, and that's a really big part of being the primary eye care provider is the whole family and knowing where the parents are coming from. So while, yes, their child is the most important thing, I've even run across parents where the cosmetics of their child is the most important thing. So you telling them that their kid needs glasses can be horrendous for some parents, and they don't even want to hear it, which is so sad because glasses, a kid would rather see, but you'd be surprised kind of where the parents are. So there's something to feeling out your audience a little bit when you're working with parents and children. And for those of you that work in pediatrics, you know that a lot of pediatrics is just parent management. The other thing, as much as you want to use straightforward language, you also want to use data. I always like to use my practice through evidence. And that's one of the reasons I love the evidence-based committee, but it's because I'm not telling you my opinion, I'm telling you what science is telling us about this disease. And so when you're working with parents, the first thing that I'm gonna ask them is, are you nearsighted? Because we know that kids who have two parents that are nearsighted are much more likely to be nearsighted themselves. And then the second question I ask the parent is, how do you feel about your nearsightedness? Now, some parents right away will tell you they absolutely hate it. They would love for their kid not to be nearsighted. And those ones are really easy to work with for myopia control. Some don't think it's a problem. And those ones are kind of more the ones where we're going to get into how to discuss it with those parents. But I think it's important to lay out the groundwork first and ask them, number one, what do you know about myopia? Are you myopic? And how do you feel about your myopia before you jump into anything that you want to discuss?
Yeah, I think that's great. I chose this picture up on the screen for a reason, because when I have patients, and this is just my personal preference, when I have to give them, we're doctors, we have to give patients bad news sometimes, or we have to explain things to them. So if you can see here in this image, there's a doctor on the left, there's a mom with a kid on the right. And she's holding up a chart or some device where it could be an iPad, it could be something where they're showing them results or showing them images. The other thing is how the patient and the doctor are seated parallel to each other instead of face to face. One of the things that I always remind my parents is that we're trying to be an advocate for your child. We're trying to take care of your child and we all have to be on the same team to do this together because, quite frankly, we're in a relationship for a long time. If you have a 7-year-old that is going to start myopia management, this kid is going to be in your practice for well over a decade. And to establish that relationship, I think the body language of the initial interaction is very important. I think it's really important to talk with the parent about working together in this kind of longer term relationship that you're building together. So I picked this picture on purpose because I think it's important to get up. We have chairs on wheels, and I tell my students this all the time. When you're starting out with a new patient for the first time, I always like to roll backwards and get a much more kind of global view of the patient's face, see where their eyes are located with respect to, if there's any disease that's, pushing eyes one way or the other. See how they're smiling, see their demeanor, see their whole face. and then roll in and get closer. But when it comes to discussing the nitty-gritty about what the problem actually is and what your goal is for them and your plan, I think sitting next to the parent like that is really, it develops a bond, and I think it really breaks down a lot of doctor-patient barriers that would be, could potentially be problematic. The other thing, and if we can, you mind if we just go down this list over here, Jackie, of talking about, briefly talking about risk factors. I think these things are, and correct me if you disagree, these are absolutes that have to be talked about with the parent at the first visit. And starting with risk factors.
A few slides to a couple before. I really think it's important that you sit down to talk to your patients. I think sometimes people just throw like, oh, your kid's nearsighted, they need to do nearsighted management, and they just kind of jump into, and this is how many visits you're going to need and what the cost is. And I think it's really important that you start out and say, first of all, this is what nearsightedness is, and that's where, showing them a drawing is really great. But the big thing for me is why we want to manage their myopia. Why is that important? And I don't think a lot of people that are nearsighted know just how many risk factors they have for other type of complications of ocular health problems later on. And we're not worried about people being nearsighted. We're worried about that nearsightedness making them more likely to get glaucoma when they're older, more likely to get a retinal tear, retinal detachment, more likely to get myopic macular degeneration. And so we're trying to do prevention, and in order to do prevention for much later complications in life, we need to act now. And I think that's really important when I start communicating with the parent. Before I get into what the risk factors of the kids is telling them why we care so much about managing myopia and making sure that they don't get more myopic.
I completely agree. I also think, how do you phrase the question? Or, let's say, kind of little Susie comes into the practice and she's a patient, and only mom comes in or only dad comes in with the patient. How do you question them? Like, what are the words that you use to ask about their family eye background? What questions are you asking them to take a complete family ocular history? What are you concerned with?
Well, I always just flat out ask for her parents, what's the ocular history for her? Things that I'm looking for, and I tell the patient this, do we have a history of glaucoma? Do we have a family history of being nearsighted? Do you wear glasses? Does her father wear glasses? And that's another nice way, if you don't really know what their marriage dynamic is, which can be more complicated nowadays, is just saying, and how about her father? Is he nearsighted at all? And the reason that I'm asking is because kids that have nearsighted parents are not only more likely to be nearsighted, but more likely to be more severely nearsighted than those who don't have that risk factor.
Got it. How, we don't have a hard and fast number, but how much do you think genetics plays into the fact that the kid will be nearsighted?
Well, we don't know how much genetics compared to all the other risk factors will make them nearsighted, but we do know that if you have two parents, you are about threefold more likely to have a child that is nearsighted.
Yeah. We were talking last night. I think what's really important, data is really important, like you mentioned before. I think having facts like that, which is all available in the guideline, in the clinical report, knowing that number, how many times more likely is your kid going to do this, or what percentage chance is it that they will develop something like this based on the information we have. I think we talked about having that data readily available is very reassuring to parents, as opposed to kind of just saying or not showing the data like we talked about before.
Yeah, well, and when you're sitting down with a parent, the other thing, usually one parent brings the kid to the exam, and then that one parent is playing the game of telephone to tell the other parent what you said.
Right.
And so having a handout, and if it were me in my practice, you could take this guideline and create your own handout for your own practice, and you can have things like having two parents that are nearsighted are threefold more likely, and then put a little citation for the study. I think citations just make everything that you do stronger when you're creating a patient handout. And you can have a little drawing, because the other thing I hate, you'll be surprised how many people are nearsighted as adults and don't really understand what being nearsighted is. And they'll be like, oh, my eyeball's shaped like a football. And you're like, well, not really. So having that drawing there that really just says, being nearsighted just means that your eye is, longer than the average eye. And it's not a lot. And that's the big thing I always tell people. I'm like, we're talking millimeters here. It's a millimeter too long. It's not so long that it's popping out of your socket and people can see it. So it's very small. And that's why measuring axial length is so important, is because axial length is the true measurement of how nearsighted they are.
Yeah, I completely agree. So let's talk about goals, right? What's your goal as a doctor? What are you trying to achieve with myopia management? And I think this is important because I think my personal opinion is, again, if we're going to have that discussion with the parent initially, talk to them how this is a long-term treatment, that we're going to be working together on this. We have to get our goals in line together. And so I really think for me, it's important to express to the parent what I'm looking for when I see their child from visit to visit. So I guess the question is, what's your goal as the doctor? I'm going to tell you that I think a lot of the parents' goals, if they're myopic themselves, or if they're a high myope specifically, they're pretty fearful of their child becoming a high myope as well, because they know what they went through. They know the psychological effects of being a high myope, the social effects of being a high myope. But what's your goal as a doctor, and how do you express that to the patient?
For me, my goal is always ocular health. I want to preserve vision, and I want to preserve the health of the eye. So
Right.
The goal is going to be very patient-centered, and we talked about this last night, I'm not treating every single kid that walks into my clinic with myopia control, because I don't know. I mean, it really depends on a case-by-case basis, because not everybody needs it. I've had kids walk into my clinic as a -1 and stay a -1, And so one of the big things is, how old is the kid coming in? Is the kid coming in at 18 at a -1, or is the kid coming in at the age of 2.5 at a -1? And how nearsighted are we? We had talked about goals. Parents that are nearsighted, a lot of them, especially if they're severely nearsighted, -8s, -10s, a lot of them are upset that they're not in, and we had talked about this, in the LASIK range. And so sometimes the goal for the group is, we want to make sure we keep your kid nearsighted in control, so they have potential to be a LASIK candidate when they're older. And I think that's a really good motivator for a lot of people, because a lot of parents are upset that they never get to be glasses free, really, until they're pseudophakic, really. So I think making sure that you understand what kind of case you're doing. And in a previous slide, we had written kind of a glaucoma example, but I treat patients with myopia in my practice the way I treat them with glaucoma. So if you think about, let's say I have a 7 or 8-year-old who comes in at -1, it's atypical, but I liken that to a person who comes in with maybe a 0.5 disc and pressures of 22. I'm not going to jump in and say right away, I think that you have glaucoma, but I definitely think you're a glaucoma suspect, in which case I'm going to do some baseline testing and have you come back in a few months and repeat the baseline testing to see if you're progressing. And that's kind of how you can control myopia a little bit, is you tell the parent, especially the ones you're not really sure, or if the parents aren't sure they want to treat, which is more often than not parents who maybe have never understood myopia or don't see myopia as really being a huge problem, and just say, your kid is nearsighted. It is a potential that they might be progressing, especially right now with the way that education is being done on Zoom and computers. So I would like to have your kid come back in a few months and we can recheck and just make sure that they're not progressing. And if they're progressing, we can talk about myopia management at that time. And it just gives you more data, and which I think is so important. Also because, and you and I know this, but a lot of kids can be pseudomyopes. We can be myopic because we're over focusing, and then you bring them back for that cycloplegic refraction and they're not that myopic. They're just a really big accommodator.
Absolutely. Tullo, Dr. Tullo, are you still available on the line?
I am.
So, pretty unique point of the conversation over here. So we're talking to parents and everything. For those of you who don't know, Bill was actually the optometrist in charge of all the optometrists at TLC Laser Eye Centers for maybe almost 2 decades, if I'm not mistaken, Bill. I just want to get your perspective from a long-term refractive surgery guy. Not to say that I'm not, but I love your opinion on it. How important is it to keep a kid in a -4 range as opposed to a -7 range from a refractive, if you're the refractive surgeon, how important is that difference?
It's everything, Andy, and great question. Obviously, when we're looking at candidacy for refractive surgery, refractive error is one of the key components to how we counsel patients and how we judge our likely outcomes. Every diopter of myopia makes the case more difficult. Every diopter of myopia increases the risk of missing our target, of needing a second procedure or having a complication. So I would love to do refractive surgery on -3 and under all day long, but in reality, that's not the case. So managing myopia at the young stage for patients who eventually will have refractive surgery is really important, and it can't be overestimated the impact it can have if we can save a few diopters from all of these young kids who, especially now during the pandemic, seem to be getting worse at much more rapid rates than we've ever seen before. I think it's really important because they are going to seek out refractive surgery, and they are going to have more complications the higher myopic they are, and the more issues they have to deal with. And so preserving myopia has a lot of long-term ramifications.
Yeah, and for those of you who aren't in the refractive surgery world, the more myopia that you have, the flatter that you have to make the cornea, and there is a limit to how flat you can make a cornea. So there is an endpoint to refractive surgery. And for those people who start out, there are plenty of myopes that have flat corneas and long eyes. If you start out as a -7 with a 40K or a 39K, while it's weird for that to happen, you may not even be able to do a primary procedure in some cases. So that's really important. I live at Walter Reed. I work at Walter Reed. And we have tons of kids that come in that have their goal is to fly a plane. They want to fly a jet for the Navy or for the Marines or whoever, the Air Force. And to be a pilot, you have to have that super high quality vision. And in jets, typically you cannot wear contact lenses. So refractive surgery is the only option. And so I know for a fact, Bill, and I'm sure you remember the numbers very, very intimately. When we looked at enhancement rates, there was a direct linear relationship between the amount of myopia and the amount of enhancements that we were doing, where the likelihood of an enhancement at any point in time over the course of a lifetime of a patient with custom LASIK or now even SMILE or whatever, or PRK, was much lower in the 1 to 3 range than it was when 6 and above.
Yeah, you're right. There's a direct relationship between your 2020, your percentage of obtaining 20/20 in every diopter category. So it's just as you said, the lower we can keep their myopia when they go to surgery, the greater their outcome, the better their outcome will be.
Yeah, and so like you said, any surgeon would love to have -3s walking into the office all day long. And it's our job as optometrists, now that we have myopia management for these progressive myopes, to try to keep them there. I wanted to pull, this is actually a section of the paper of our clinical report. Why should myopia management programs be discussed with parents and patients and caregivers? Bill asked me and Jackie to do this presentation, and he said, hey, we have an idea. We have this device called the Myopia Master, and we want to talk to folks. We want you to talk to folks about how do you talk to a parent? And I said, Bill, it's really funny because we actually put a section in our clinical report on this. So it's important to discuss a risk of for child development or progression with parents and or caregivers. Although heredity and ethnicity play an undeniable role in myopia development, it is also significantly influenced by the visual environment. Discussion with patients, parents, and caregivers should include a comprehensive review of the causes of myopia, the risks and consequences of the development and progression of myopia in children, and the treatment options currently available. Emphasis should be on the long-term benefits of reducing myopia progression and related ocular complications. There is a need to manage parents' expectations. The goals of myopia management are to slow the progression of the myopia and not eliminate it. And that's a really important thing because, Bill, I can remember, with LASIK in the early days, everybody had that expectation of getting perfect 20/20 vision 100% of the time. And when it comes to refractive surgery, when it comes to cross-linking, when it comes to glaucoma management, all of these diseases, what you have to manage patient expectations, because for myopia control, there are some patients that think, oh, my kid's getting myopia control, they're going to get rid of their glasses and never have myopia for the rest of their life and have none of the complications associated with it. And I know Jackie is going to talk about this in a second in terms of ocular injury as well, and risk. But we have to tell these parents that what we're trying to do is halt it or slow it down. Slowing down the progression is still a great outcome from this. We don't necessarily need to stop it at anybody, but if we can take a kid who had the potential to be a -8 and slow their progression down to be a -5 or a -4, we did a lot of good. Children will still need to wear glasses once their myopia control therapy ends, and this is really important. And you know, Bill, I'm going to call on you one more time as the head doc for TLC. Could you talk about informed consent for a second and how important that is, and really what was the refractive surgery informed consent process?
Yeah, well, the informed consent process involves everything from documents given to patients, conversations having with patients. It's not a single thing. And I think with myopia management, I think because a lot of the things we do are off-label or they're not FDA approved, I think explaining this to patients and gaining that informed consent to move ahead with things, because we know that a lot of these treatments are effective, and just because they don't have FDA approval doesn't mean that they aren't safe to use on your patients. So that's when your judgment and your expertise comes into play, and the parents need, though, to understand these things. And so informed consent is really crucial in this area, just as crucial as it is in surgery.
Yeah. And Jackie, I have a question for you. Is how do you document? Do you use paper charts? Do you use electronic charts? How do you document what you say to your patient base?
So we use, I mean, it's been different depending on where I am. When I worked, at UC Berkeley, they have a whole kind of paperwork that everyone has to fill out, and I believe, I want to say they have some of it actually online. But essentially, it goes through all the documentation and essentially says, a lot of the treatments, for instance, atropine is an off-label use. Off-label doesn't mean it's bad to use. It just means that it hasn't been officially approved by the FDA just yet. Doesn't mean it doesn't work. And then going through the side effects. So the big thing is just making sure that they have a list of what the side effects can be. They have contact information if they feel like they get a side effect, which is usually just your office's number. And then just having a parent sign it and scan it. So for our office, we do a lot of just scanning consent forms and just, documenting. Today, I discussed myopia management protocols with patient and parent. They are interested, and then if they're interested, I write like consent form signed, and I always just put it in my chart to know that I did that step. It's always important to make sure that that step was done and it was never skipped.
Yeah.
And then also documenting in there, I went over because I did a lot of atropine when I worked at Kaiser, I went over the risk factors and the adverse events that can happen with atropine with my patient. Because there's an old kind of knowledge out there that if it's not documented, it did not happen. And so you can never go back, oh, I totally said that out loud. Well, if you didn't document that you said it out loud, it never happened. So it's important that you get, in my opinion, if you're doing anything that's off-label, that you get it definitely written down. But I would even argue doing both. So getting it written down and just saying out loud, like, hey, this is off-label, and just going over everything, because you never want, I mean, I don't foresee a lot of lawsuits coming from myopia control, but you never want to put the risk or liability with it.
Absolutely. I completely agree. And, hopefully there won't be lawsuits associated with myopia management. But, the most common reason, just so everybody's aware, the most common reason why an optometrist gets sued in the United States is failure to diagnose, specifically with glaucoma. And so I think informed consent associated with that for failure to diagnose or failure to disclose, all of that information can be easily resolved by a proper informed consent.
Well, the other thing too, the most common reason people get sued in pediatrics is amblyopia. And what's interesting about that is, so while atropine is not approved for myopia, atropine is FDA approved for amblyopia and at a stronger dose than we use for myopia control. So it's not that atropine's not used in pediatrics.
Right.
Just making sure that you document it. And I usually tell that to parents, like, hey, there's a stronger dose of this on the market that is approved for use in kids. And that usually makes them feel better about it if they're deciding to do the atropine route.
it does get me into, I'll tell you, it does bring up an important concept that, if you want to, you're a numbers person, I'm a numbers person. One of the things that I always talk about is the use of atropine with my myopia management patients. I think it's really important to know if the doc knows to say this to the parent. So let's say the atropine is going to be your modality of choice for this patient. I think it's important to tell the parent, be like, look, this has been FDA approved. Hundreds of thousands of kids have used 1% atropine for months at a time. I'm asking your child to use one off-label, 1/100th of the concentration, essentially, that all these hundreds of thousands of kids over the years have used in a safe environment. So I think it's important to know that data so you can express it, because when a parent hears something like that, when it's such a dilute version of an FDA-approved drug that's been used so many times, they feel a lot safer about moving forward with it. That's just my personal opinion, but I can't stress enough about the informed consent process. So what if you come in, you're in your pediatric clinic, parent comes in for the annual back-to-school eye exam. You notice that from year over year, they've developed a diopter of more myopia, and you start talking about myopia management, and then they say, but the glasses work fine. I wore glasses as a kid. What the hell's the problem with glasses? I don't think there's anything wrong. Why do I need to do anything? Other than the disease aspect, is there any, from a sports perspective, and I'm leading you into this question a little bit, or a social environment, is there anything that you discuss with those parents?
Yeah, so for me, glasses are great. I think they're a wonderful tool, but they definitely inhibit our ability to play sports. And so if we're going to go into sports, not only do we need a pair of glasses for school, but we also need to get a separate pair of glasses, rec specs that are polycarbonate or Trivax, to make sure that the kid can also play safely while playing their sport. And when we look at kind of eye protection from a myopia standpoint, the other thing that I always want people to remember is, just because, let's say you're doing, myopia control with atropine, they're still going to be wearing their glasses. So you're right, glasses work fine. But if you decide to go the contact lens route and you're using Ortho-K or you're using multifocal contact lenses, a lot of people like to transition into that for sports anyways. Right. And so one of the things that you have to keep in mind is as the kid becomes more nearsighted, they become at higher risk for getting injury to the eye, specifically if they play sports like tennis or racquetball, anything with a small ball that can enter the globe, and they're at a higher risk of a retinal detachment. So for some kids, even though you have maybe switched them over to the contact lens modality, you do still need to counsel the parent that it's also important that they still have protective eyewear, which could be glasses on top of their contacts if they're a higher myope. So if they're a -4, 5, or above, they might need contacts and even plano rec specs on top to make sure that you protect the eye in a smaller ball sport. And that can sometimes deter parents one way or the other on which way they want to choose for their modality as far as, what we're going to do as far as sports goes.
Yeah, the last question I want to ask you before we get into the device that Oculus has on the market right now is screen time, because we're in a really weird situation. So here's the American Academy of Pediatrics. Here's their recommendations for screen use and kids of all these different ages. But this was written prior to the pandemic, right? And so I've got two kids, 14 and 17, and I, as an optometrist, and I'm a big mocker with the myopia clinical report, and I'm reading all the pediatric guide. I can't keep my kid off of their device. We're living in a pandemic right now, so we know screen time. Increased screen time and decreased outdoor time is an environmental challenge, and it's a stressor that increases myopia. But how do you handle this? Because one of the dilemmas that we have is that kids just got out of a year of online school. Online services are getting more and more popular. The use of handheld devices is higher than ever. So what reality-wise, what do you tell your parents?
So we know that it's not just necessarily screen time, it's also just near tasks in general. And so screen time is an issue because it's at near, but even just reading. And so one of the things that I always say is, now I don't really have to say, but I used to always be like, well, how much is the kid on the screen? And I'll still ask, but it's always a surprisingly high number because they're on the screen all day at school, and then they come home and they have school work. So, these kids are on their devices way more than we are. And you're not going to be able to say like, oh, well, your kid's nearsighted, they should get off their devices because what are they going to not do school? I think it's actually one of those things that says, I know that the American Association of Pediatrics has said that we should limit screen time, but I think we all know, especially right now in our reality, that it's not possible. And I think it supports pursuing myopia control even more because we know that prolonged screen time is a higher risk factor. While I would love it if we could tell all the kids to just go outside and play all day, it's not realistic. And so it's better for us to kind of say, this behooves us to consider it or follow you more closely. I will say this, a lot of us started seeing our pediatric patients, maybe we saw them yearly, now we're seeing them every 3 to 6 months to monitor for progression because we know that screen time is up. And so for me, I will ask, how much screen time are you on? And that will also help me dictate how soon I want them to come back for me to just check and see if they're getting more nearsighted. And you know what? If they're on screens 12 hours a day and they come back in 3 to 6 months and they're not more nearsighted, great. But if they come back in 3 to 6 months and they're more nearsighted, then we're going to have that conversation about myopia control again. And I think a lot of myopia control is planting the seed. It doesn't mean you're treating them on day 1 of diagnosis of myopia. It's planting the seed to let the parent know there is something we can do if it's getting progressively worse.
Yeah, completely agree. Just to hit on a couple of hot topics real quick, something that we might not feel comfortable talking about. I think it's really important to understand the family dynamic. Parents get divorced. Kids have split custody with their parents. If you're going to put a kid in a certain type of modality, I think it's important to understand the family dynamic. One parent might feel comfortable with contact lenses and one might not, and that may shift you towards, it's about consistency. So maybe atropine may be the best option for those people. So just because we have a lack of time over here, I just want to remind everybody unfortunately, we have to engage in some of those uncomfortable family dynamic situations because really we're concerned with the child, and understanding the lifestyle of the child and the family dynamic is really important. Combinations, sometimes a combo isn't just a burger with fries and a Coke. Sometimes you can combine some of these treatments together. If you're not getting the desired results, all that information is actually in our clinical report. We talked about protective eyewear. I think that's incredibly important, that even if a kid, if they have that long eye, it's a more at-risk eye. If kids are used to wearing glasses and now they're out of their glasses, they don't have that protective value. So take that opportunity to talk to your children and parents about utilizing protective eyewear. The last thing I want to talk about here before we take questions is the device that Oculus developed. And so this device is called the Myopia Master. I want to make everybody aware that just like certain drugs and certain devices that are FDA approved, there is always approvals for certain indications. This device was approved to measure refraction, axial length, and keratometry. The indication is not specifically to do myopia control, but it's to take all these measurements with one device, and I think that's important. That being said, if you go to our guideline and look about what tests are needed for myopia management, a detailed comprehensive eye exam, but with that, having a great autorefraction, in my opinion, especially a cycloplegic autorefraction, is really important. And it really, when you measure cycloplegic autorefraction to cycloplegic autorefraction over visit, you have very solid comparative data. Also, axial length. I'm going to say this because it's important. The treatments that we're doing, and I think I said it before, the treatments that we're doing are meant to slow the axial length growth of the eye. If you want to do myopia management properly, you have to measure the axial length of the eye. The other thing is understanding keratometry readings. K's of the cornea is important to establishing axial length. If your refraction gets worse and your K's stay the same and there's no injury or disease, most likely you should be looking for an axial length change of the eyes. And that's why I think this device is so valuable for an optometric practice or any eye care provider, could be an ophthalmologist as well, that's doing myopia management, because it gives you those measurements. And again, the indications for this device, the FDA approved, was for the measurement, not as an FDA approved myopia control device. Within the device, it measures all of this information, and it also has in it the Brian Holden Vision Institute estimate data evaluation on where the patient will end up with and without myopia control over time. So that's really important. You get your K readings, your overall keratometric power, your astigmatism, a really solid autorefraction, and also the axial length of the eye, which is fantastic. And the cool part about this is that you can pop one of these off every time the kid comes in and then compare automatically on the fly. It's quick, it's contactless. The measurements, just like most OCULUS, all OCULUS devices in my experience, are incredibly accurate, repeatable, and reliable. One of the things I told you about in the beginning was a report that we're developing right now, and this is a third-party software. It's not an OCULUS product, but hopefully, well, it will. The data will transfer over, and then you can print this out and give this to the parent, so the parent can actually keep track of all this stuff. And that's what we have on it. So I just want to say thank you to Dr. Theis. It's been an honor and a pleasure speaking with you, and Dr. Tullo as well, and the team at OCULUS. We really thank them for the opportunity to do this. And I think, Bill, we're going to open it up to some questions because we have a little time left.
Fantastic. Great job, guys. Really learned a lot. A couple of quick questions, and the first question I have goes to your family dynamic conversation. And it says, if you had a potential ortho K patient that actually lives in two homes, I guess because the parents are separated, or some other family dynamic, do you insist on bringing both sets of parents in for, I guess, insertion and removal training before fitting the lenses, or are you comfortable with just one parent?
So this is Andy. I've had this experience. The reason why I put that slide in is because I actually had this experience multiple times. And so I've had a situation where a parent brought a kid in and didn't tell the other parent that they were starting myopia control. And we got a phone call, a week or so later that, the other parent, I never gave consent. I never wore contact. The patient ended up getting ortho K as a modality because parent number one thought it was awesome because it was a kid who was an athlete and they wanted him out of glasses. And the other parent was adamantly against it, and they split custody of the kid. And what we agreed upon at the end was, I think, again, it's really important the key here is consistency. This kid's going back and forth between two houses, two parents with two different views. You got to get everybody as close to on the same page as possible. I generally, if it's a contact lens environment, I'll switch them over to atropine. The eye drop is a much easier modality. We can say that, hey, we understand the situation. Let's start with atropine, see how it goes. Let's keep a tight eye on your kid. The kid's the most important person in the room here. Let's, instead of getting involved with the whole ortho K, insertion, removal, contact lens, this, that, and the other, let's just bring him back a little bit more frequently and keep a tight eye on him and make sure that myopia is not getting worse. If it is, then we're going to agree to combination treatment. Maybe we'll do ortho K and atropine at the same time. And if that happens, you kind of bend over backwards to make the parents comfortable, because if the kid is not using the treatment, it's going to get worse. We have to establish long-term chronic care. And however you have to do that is however you have to do it. Just try to do it the easiest way possible first. In my personal opinion, I think atropine is a very reliable treatment. And I think it's the easiest method for non-contact lens wearing patients or parents that are kind of a little weary of it. That's my 2 cents.
Even if you do atropine, I would still say you need to make sure both parents can get the drops in. So
Yep.
If you need to bring them both in for installation training, whether it's contacts or drops, you can do it. And you have to ask the parents, are you comfortable coming in together to learn, or do you need 2 separate appointments? And each family's different. And then the other thing is, I've had some where you have to get a little creative and ask, what is the likelihood if you do contacts that the kid's going to consistently be able to remember to bring their contacts when they go from one house to the other? Because sometimes you have to order 2 pairs. Or when I've done atropine, I've had to order 2 actual separate bottles of atropine, one to stay at mom's house and one to stay at dad's.
Absolutely, I completely agree. It's another opportunity. It's a great opportunity for the doctor to start making some in-house YouTube videos that they can potentially just email out, it's eye drop insertion, contact lens insertion, all those kinds of things where you can easily email them to the parent. And also, this is a personal preference. I don't mind giving my patients my cell phone number. If they have a question, they can text me. If I'm available, I'll call them back. But you're trying to develop a relationship with these people. You're taking care of them for a long time. I think it's important for the parent to have access to the doctor.
Yep.
Andy, the next question, and I'm not sure if we have an answer for this, but it's a good question. Can you recommend any places where we can find consent forms for either orthokeratology, atropine, or myopia control?
Sure. So let me just say that Dr. Theis, myself, the American Optometric Association, Oculus, Bill Tullo, anybody on this call does not endorse any one product or another. We're not lawyers. That being said, I have seen some great options on a free website called ODs on Facebook. Alan Glazier runs the page, and he has a section where fellow doctors have uploaded forms that they use themselves for their practice. I think Justin Bazan, B-A-Z-A-N, has uploaded some on ODs on Facebook. I'm not endorsing them. I'm not saying they're legally correct. I'm saying that's what I've seen. So I think that's a great resource. And I would get on the page and also just pitch a question out there. Be like, hey, does anybody have any myopia management consent forms that they wouldn't mind sending me? I don't think that's an unreasonable thing to do. I know in the ophthalmology world, if you go to the OMIC webpage, OMIC, and I forgot what it stands for, but I remember that they have a section on their page that have loads of informed consents for different surgical procedures. I don't know if they have one on myopia management, but you can see on there at least what a surgical consent form looks like or a procedural consent form looks like. OMIC is the largest ophthalmology malpractice carrier in the United States, so they have some experience with this stuff.
All right, docs, I've got one final question, and this probably goes back to the work you both did on the AOA evidence-based materials. But if when you did the research and you were writing up the guidelines, is there any other research that you feel is really necessary in the near future regarding either ortho-K or myopia control in any way? That what gaps did you find in the literature? And is there any one thing that you can say that you're looking forward to that research coming along soon?
I know what I'm going to say. Jackie, do you want to hit this one first?
I was going to say, well, we were talking about this last night because we got into a discussion of, so we know that atropine has multiple doses that you can do and they have different effects. So, right, so we know there's 0.01, 0.02, and 0.05 that's usually looking for atropine treatment, and 0.05 is better for stabilization of the eye, but it has more rebound effect when you stop it, and so you can go back and forth. So the question is, do you start with 0.01 and then go 0.02, 0.05, or do you start with 0.05 and then go back? So that for me would be one, is which one do you start with? Would be the better one for me.
That's a great one, Andy. What are your thoughts, Andy?
So I completely agree with Jackie said. The question of like, what concentration do you start with? Where do you begin? Is there a definitive? I know that people have summarized, and one thing is better than another. The ortho-K crowd says ortho-K is the best. The soft multifocal people say that soft multifocals are the best, and the atropine people say that atropine is the best. I think as we learn more and more and more over time, and again, it's all about data. It is all about understanding results and collecting this information so we can understand what modality works best. The other thing you have to remember is we're still in the dark, for lack of a better term, of what the mechanism of action of these drugs and devices are on slowing down progression of the eye. We think we know a lot, but I think we're going to learn a heck of a lot more over time about why the eye becomes myopic. There are studies out there that we found, and there are papers that look at, in China, if you look at a population of children that work in incredibly rural China that are really not in school for that long, if anything at all, they're more from a farming population, you'll see that the rates of myopia are like below 10% of the population. But then you go to the urban environments where these kids are in class all day long, on devices, computers, this, that, and the other, all that near work that Jackie was talking about, the rates of myopia are like 70, 80% of the population. So, there is something that makes the eye more myopic, and we want to know for sure what it is. And once we know for sure what it is, we can tailor our treatments better and more accurately for the individual. And I think that's really where the research is going, and we're learning more and more. We're going to get better with prescribing. We're going to get better with making, with LASIK started out, Bill, we had one optic zone, right? We had a 6.5 millimeter optic zone for every single patient. Every patient with a -1 got the same exact treatment. Once we came out with custom LASIK, and we learned about higher order aberrations and how to reduce coma and spherical aberration and trefoil, the outcomes just got better and better and better. I also think patient identification, and like Jackie was talking about earlier, not every patient is right for myopia control. Who are the best ones for the best modalities of treatment? I think when we learn more of that stuff, and it's all about data collection. You've got to get that information into some sort of repository on a very large scale. That's why, when the AOA, and not to promote the AOA, but they do a great job of doing a lot of things that a lot of people don't know about, having the eye disease registry and the diagnosis registry that the AOA stood up, so we can get all of the data collected on patients and how many people have diseases, so we can allocate resources better, and we can actually talk about scope of disease and burden of disease, and really what you should be looking out for when patients come into your office. That's really important. Bill, we've been doing keratoconus work for years and years and years, and we didn't know the true prevalence of the disease until we had the Pentacam show us how many patients had keratoconus on the posterior side of their cornea. And once we learned how many patients had posterior corneal keratoconus, we learned the prevalence of the disease wasn't 1 in 2,000. We learned it was more like 1 in 450. And so when you have a disease where the burden of the disease in the population changes, you can actually look at it more accurately and more distinctly. So because if it's a higher prevalence in the community, you should be diagnosing it more. And so all of this data information that we're collecting is so incredibly important. Myopia control is only going to get more accurate with time, the more patients that we have and the more accurate results that we have. And so recording this data accurately is incredibly important. I think a device like the Myopia Master, not because this is an Oculus call, but I think stuff like this, whether it's this device or another device, is really important to use, so you can collect your data accurately, repeatably, and use that data to refine your outcomes and refine your procedure methods, so your outcomes will ultimately get better. I'm sorry I'm rambling there, but
no, that's great, Andy. It's all great information. I appreciate you sharing. The one other question that I'm just going to touch on is how easy is it to capture patients on the Myopia Master? And I won't go into detail other than to say is you should try it. Hopefully you can be at a live show sometime soon. I've been able to capture 6-year-olds with it easily. It's fast. It's very simple. It's non-invasive. But I think if you're looking to purchase one, you've got to touch it and feel it and see how easy it truly is to do. So with that, I'm going to close tonight's webinar. You guys did a great job. It's clear that this topic deserves way more than an hour. So maybe we'll look at touching on more aspects of myopia management in future webinars. But again, thank you guys both for staying up late, and I appreciate everyone. And if you have any other questions, we'll try to answer them after we're offline by email. Thanks again, and have a great night.
Thank you.